We take our RV up a couple times a year and watch them play. But that yesterday he did not know that. It's not his fault. I'm sure he had that. His kids are so cute though. Saquon Barkley's kids are so cute. It's like one of the best highlights. We talked last week about the main causes of vaginitis and vaginosis. We talked about bacterial vaginitis, we talked about candidiasis, and then we ended talking about trichomoniasis, which is an STI. Remember that bacterial vaginosis is not an STI, so you don't need to treat the part of the trichomonas, you do need to treat the partner. We do what's called expedited partner treatment, meaning you don't have to have the person come in, you don't have to test them, you're just automatically going to assume that they have it, even if they're not having signs and symptoms, and you're going to treat them. It's I don't know if it's a little bit easier maybe in the military system, but in general, the problem is you got to get a hold of these people somehow. Because you've got to have a little conversation with them about if they're allergic to any medication, are they taking any medications, before you just throw some medications in the pharmacy for them to go get. So it does require a conversation either between you and the partner, or depending on your work, where you're working, sometimes you'll have a nurse that does these follow-ups for the STI checks, and they'll be the one that can with the partner and make sure the partner's treated. So we'll continue on with some other STIs, and again, these should just be reviewed for you, hopefully I can from probably ID, I imagine. Chlamydia, about 70% of females with chlamydia are asymptomatic. Okay, so they don't typically have a significant amount of discharge, they don't have a foul smell. About 50% of men, if they do have signs and symptoms, it will be vaginal discharge. Usually it's more of a kind of a yellowish color vaginal discharge, thinner, and their presenting sign or symptom may actually be just lower abdominal pain. So your evaluation for lower abdominal pain, your differential should include STIs. It should include maybe a self-swab or a pelvic exam, including a pelvic exam in this patient. We diagnose this with a pelvic swab or vaginal swab, the NAAT, or urinalysis. So if someone's coming in, you have a low abdominal pain, one of your differentials should also be urinary tract infection, so you're probably going to send a urinalysis on them. With that urinalysis, you can add a gonorrhea and chlamydia test. And these are done as co-testing, meaning with one swab or one urinalysis specimen, they'll do both gonorrhea and chlamydia. Treatment for non-pregnant patients, it's been this treatment for many, many years. Doxy, 100 milligrams twice a day for 7 days, usually pretty well tolerated. For pregnant patients, we're going to do azithromycin. Doxycycline is not recommended for pregnant patients. Again, EPT, expedited partner treatment, is what's recommended. We should consider co-testing, or co-testing for other things, other STIs, like syphilis, like HIV. And then this, again, is done with gonorrhea already. Abstinence for that 7 days while they're on the antibiotic. That is recommended for all STIs. So a total of 7 days. If the antibiotics, let's say it's a pregnant patient, the antibiotic is azithromycin 1 gram PO times 1 dose, the still abstinence recommendation is 7 days. Not, you can use a condom, you can do all these other things. They recommend complete abstinence for these patients. And that is going to help minimize our reinfection rates. No test or cure. You guys know what that means? It means you don't have to come back in 3 or 4 weeks and you retest them. We screen them. Hey, are you having any signs or symptoms? Are you having any new sexual partners? Are you using protection? But you do not need to retest. If we retest and everybody has chlamydia, that's going to be, I mean, we got almost probably 2 million cases of chlamydia a year. That's one of the most common STIs you're going to see. And for those of you going to Fort Hood or whatever it's called, Fort Shows, that's like chlamydia capital. So you don't need to retest. You just need to rescreen for these patients when they come back to see you, make sure that they're not. If they're pregnant, then the recommendation is to retest them in pregnancy because it can cause a lot of pregnancy complications. These patients have persistent chlamydia. or the azithromycin doesn't work, which is occasionally what happens, then you're at risk for premature rupture of membranes, preterm delivery, and ascending infections like chlamydia. Otherwise, we just rescreen these patients. Gonorrhea, again, many women are asymptomatic. Most men are not asymptomatic. They'll come in with this very profuse green discharge that's just kind of leaking out, essentially, for men. For women, the discharge does also tend to be like a greenish hue, so kind of light green. But again, many women are asymptomatic. We're going to do the testing with the chlamydia, the NAAT, vaginal swab, or urinalysis as co-testing. And the primary treatment is going to be ceftriaxone, 500 milligrams IM. If you're reading literature that's 5 or 6 years old, it'll say 250 IM, but because of antibiotic resistance, we're up to 500 milligrams IM. Now, I have on your plus doxycycline. Okay, so the doxycycline is a treatment for chlamydia. Depending on what you read, depending on what you think, there's a lot of places that will do co-treatment. Even if the chlamydia is negative, they will do co-treatment for both. So if you're positive chlamydia, they'll co-treat for gonorrhea. If you're positive for gonorrhea, they'll co-treat for chlamydia. Okay? So again, it depends on what your thought is, depending on where you're working. For us in the emergency department, we typically co-treat because we don't have, most of the time these patients aren't coming back to see us. For primary care, you guys can make that decision as you go on to continue your treatment beyond phase 2. We used to treat with fluoroquinolones. We used to use ciprofloxacin, but that is no longer recommended, again, because of antibiotic resistance. And then we want to treat the expedited part of the treatment. We want to treat all sexual contact. We want to consider testing for those other STIs, syphilis and HIV. And then abstinence, even though the ceftriaxone is 1 dose, we're in the abstinence for 7 days. Same thing, no test or cure is needed, only be rescreened in 3 to 4 months unless they're pregnant. And then the recommendation is retesting them in 4 weeks to make sure that they're having this problem. If we do not diagnose and appropriately treat these STIs, these patients have a risk of PID, pelvic inflammatory disease. Essentially, pelvic inflammatory disease is an upper genital infection that results from a lower genital infection. Okay? And it's really important that we diagnose and treat this appropriately, otherwise these patients are going to come in complaining of infertility. They have increased risk for ectopic pregnancy, increased risk for chronic pelvic pain as well. And most commonly, we're going to see this from chlamydia, gonorrhea, bacterial vaginosis as well, and then this genital mycoplasma. So genital mycoplasma, we have mycoplasma that resides homeostatically within the vagina. But when it overgrows, it can increase the risk for PID. The problem is we don't test for this routinely. It's not a test that we do on a routine basis because if the patient is ultimately, if they're asymptomatic and you're testing for this, there's no treatment for it unless they're symptomatic. So what they would do is they would check this patient for gonorrhea, chlamydia, bacterial vaginosis, and if that's negative, then they can send a culture for this mycoplasma. Otherwise, they don't typically worry about it. Risk factors for PID, of course, if they have an STI, that's the risk factors. Lower socioeconomic status, douching, substance abuse, because we kind of think that more associated with maybe multiple sexual partners. And if they have a history of PID, that increases the risk of having PID again. Anytime they have an IUD placement, which is, remember when we talked about IUD placements, one of the main things we have to make sure is they don't have any evidence of vaginal infection. You don't want to put an IUD into a vaginal infection. Also, they run the risk with a recent IUD placement in that first 4 weeks or so of getting PID. So we want to have that high differential. If someone recently had an IUD placement coming with lower abdominal pain, with fever maybe, vaginal discharge, have this on your differential. So how these patients present, again, fever, chills, lower abdominal pain, they have pretty significant vaginal discharge. They may have, depending on how long it's been going on, they may have something like dysmenorrhea or dyspareunia. They may have UTI symptoms where they're having pain or burning with urination. they could, if they've had this for a while, they actually could have something called Fitzhugh-Curtis syndrome, which is right upper quadrant. So you ask them, any vaginal discharge, any new sexual contacts, any urination? No, 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 no. I just have this right upper quadrant pain. That's all I have. And what it is that infection will ascend and it'll get around the liver and cause an infection, kind of like an abscess around the liver. And these patients will do an ultrasound down in the ultrasound of the gallbladder and the liver. Looks okay, except for they'll notice this fluid around the liver. I have seen this on a handful of occasions, and every one of these patients, none of them complain of vaginal discharge. So you want to have this high on your differential for patients coming in with abdominal pain. So your diagnostic criteria for PID, uterine tenderness or adnexal tenderness or cervical motion tenderness, plus one of those multiple other things. So either they have a fever, or they've got mucopurulent discharge from the cervix. When you do your vaginal exam, you can see a bunch of pus coming out of the cervix. Maybe on their microscopy, when you send that off to lab, they see a bunch of WBCs. ESR and CRP, we all know that those are really not diagnostic of anything, but they're inflammatory markers. If they're elevated, it gives you an indication that potentially, along with that uterine tenderness or adnexal tenderness. Okay, but most commonly, we think about cervical motion tenderness. The problem is, if we think about all the things we've talked about, there's several things that can cause cervical motion tenderness. Endometriosis can cause cervical motion tenderness. So that by itself is not going to give you your diagnosis. Cervical motion tenderness with a bunch of discharge and a leukocytosis, that's going to give your diagnosis. So please make sure that you're familiar with these diagnostic criteria because you will see these again. How do we evaluate those? How we diagnose this? On clinical exam, we're not really sure. To do transvaginal ultrasound, right? CT abdomen pelvis, maybe, because maybe they're coming with lower abdominal pain or upper abdominal pain, so we're using that to assess for that. MRI and laparoscopy are typically not needed unless it's kind of a diagnostic conundrum. We can't really figure out what's going on. Usually this is not all that difficult in the acute setting. You can have something called silent PID. Now this is still an upper genital tract infection, but it's occurring over months and months and months. So maybe this person had undiagnosed chlamydia, and now they're coming in. So I've been trying to get pregnant for the last year, haven't been able to. So they're coming in with infertility, and they do what they call as a hysterosalpingogram, so looking at the fallopian tubes, and they notice that there's stenosis there, there's scarring there. They may sometimes take a biopsy and it's positive for chlamydia, right, or gonorrhea. Usually it's going to be chlamydia. And so these patients can then ultimately be treated for that. And the problem is that scar tissue doesn't go away by itself. So you usually have to have some sort of instrumentation to be able to open up those tubes. So silent PID, these patients are often asymptomatic or they're having symptoms, but you know, it's not unusual for females to have vaginal discharge. So they don't really think much about it until it's been several months that they're having it or they're coming with infertility. How do we treat these patients? So outpatient treatment is okay in the majority of these patients. We'll talk about inpatient treatment in a second. But outpatient treatment, we can put these patients on ceftriaxone, which they should get in the clinic or wherever you're seeing them before they leave. And then you discharge them with doxy plus metro. So doxy is a triple drug regimen. So metronidazole, doxy, and not 7 days, but you can see on your 14 days of treatment for both of those. The ceftriaxone, also look at the dose, 1 gram. You know, for testing purposes, you don't need doses, but you need to remember that the dose is different for PID than it is for when we talk about gonorrhea. Double the dose of ceftriaxone and twice as long for the metro and the doxycycline. Okay. If they have severe systemic symptoms, so they're having fever, they've got a high white count, they're PO intolerant, these patients may need to come into the hospital. And the treatment is still the same, it's just given IV. So IV ceftriaxone, and then they'll put them on doxycycline and put them on metro. As they continue on outpatient, they'll continue on that doxy and that metro for that total of 14 days. Inpatient criteria, if they're pregnant, someone that's pregnant with PID, those patients can get super, super sick. They need to come in. adolescents, so young kids, usually under the age of 16 or so, will bring those patients into the hospital. Again, if they're PO intolerant, have evidence of severe disease, where they're running that fever, significant lower abdominal pain, those patients probably need to come in. If you try them as an outpatient and they failed outpatient treatment, either their symptoms continue, they had a fever persistent beyond 4 days, they have been taking the medications but they're just no better, usually once we start these patients on the antibiotic, we should see some improvement in 3 days. And that's what I tell all my patients with most antibiotics. I'm like, look, tomorrow you're not going to feel better. 48 hours, the antibiotic is just starting to take hold. So about 3 days. If beyond 3 days you're still fevering, you're still not feeling better, then we probably need to see that. And that's the same thing with this. Or if they have recent instrumentation, so recent IUD placement, that is an indication for considering these patients to come in inpatient hospitalization. Doesn't necessarily mean you need to remove the IUD. We just got to treat the infection that's associated. All right. Genital herpes. So genital herpes most commonly caused by HSV2. We know there's a high likelihood now of kind of co-infection with HSV2 and HSV1. Over 570,000 cases of HSV in the United States annually. Okay, so this is very, very prevalent. You guys will definitely see it. Most of the time what will happen is these patients will come in and they will have some burning sensation or irritation. They're like, I don't know, I feel like maybe I hit myself somewhere, whether it be on the buttocks area or the perineal area, but you don't see anything. Physical exam, you don't see anything. That's that first couple of days. Once you start seeing this more and more, then you can tell these patients, you know what, I would watch over the next couple of days and see if you don't develop some blistering in that area, because it sounds like you probably have herpes. Because 70% of these patients are going to transmit it during that prodromal time period. So it's usually once they have the lesions, are not as infected as they are during that prodromal time period. So once we identify that this person in fact does have HSV, we want to tell them no intercourse or no direct contact during that prodromal period. How do we transmit this? Either direct contact with the lesions, direct contact with the patient in that area, or via saliva. Unfortunately, we can treat this, but we cannot cure it. Okay? Once this gets in the body, it kind of lives at the dorsal root ganglia, and in times of stress or anxiety or just whenever it wants, it'll come out, and these patients will have a reoccurrence of these lesions. But most of the time, you're going to have this prodrome, this tingling, this itching, this burning sensation. The lesions themselves are painful. They typically will occur about 2 to 3 days after they have that onset of that prodrome. And you can see lesions just about anywhere in the perineum and the perirectal area, even into the cervix and up by the urethra. Sometimes we even have a lesion in the bladder. Obviously, you can't see those. Their primary infection, their first infection, that's when they tend to be the most symptomatic. They can have fever, myalgias, headaches, and actually they come in because they feel like they have the flu. So you want to ask them, are you having any other skin sensation? Anything specifically on your skin that's bothering that you feel like a burning sensation? Otherwise, you will probably think, because the patient's going to convince you that I think I have the flu. And you're like, you're right, you probably do have the flu. And then you're going to miss this. And they'll come back 4 or 5 days later and say, oh, now I have this rash. But the rash is going to be in one specific area, and it's going to look like this blistering on the erythematous base. So we have multiple vesicles and multiple small blisters on this erythematous base, and usually, again, going to be in the perineal area. Diagnosis is usually a clinical diagnosis. Once you've seen it once, you'll never forget it. It's usually pretty darn obvious when you see it. You can swab those lesions and send them off. You can do blood tests. So there are some people that will come to you and say, I think I was exposed to somebody with herpes. I want to be tested to see if I have it. So you can do that, but the tests aren't terribly reliable. So just because it's negative doesn't mean that they have not been exposed. If it's positive, it means they've been exposed. You have a lot of false negative rates associated. So you just got to kind of talk to your patient and counsel your patient on the potential for false negative. So ideally, we want to reduce our patient's chance of even getting herpes. Okay? Talk to them about refraining from any sort of intercourse and someone that's having prodromal symptoms, or if they're having prodromal symptoms and they don't have intercourse with others. Okay? If they do have signs and symptoms, the recommendation is to get them treated within 48 hours of the onset of symptoms. If we go beyond 48 hours, there's really no reason to give them medication, okay? Because it's really just gonna run its course over the next week or so. If we can get them treated, it'll be within that first 48 hours. If they come in at day 4 or 5, they're gonna still want treatment. You'll say there's no need for treatment at this point. We've got another couple of days of this, and it's gonna continue to get better. If you're gonna treat them, valcyclovir is one of the common medications we can use. Acyclovir is okay as well, but acyclovir is multiple times a day, like 5 times a day. So most patients don't do that very well. Acyclovir is okay. It's a little bit more difficult to find in the military setting, so usually we use valcyclovir in the military setting. And I don't have the doses on there because it really just depends on what you're treating for these patients. You don't have to, if it's the first episode, if you're putting them on episodic therapy, or if you're putting them on suppressive therapy. There is a medication called topical acyclovir, not typically recommended. We thought it was going to be, this came out about 20 years ago. We thought it was going to be a great medication for HSV, but unfortunately did not going to provide much of the benefit for the majority of patients. For patients that are having recurrent outbreaks of HSV, we can put them on suppressive therapy. So if they're having 6 or more outbreaks a year, if they're immunocompromised, or if they have HIV, if they're solid organ transplant, then you can consider putting them on suppressive therapy. Usually we're going to use valcyclovir for that. Oftentimes you can do a year or 2. Usually what I'll do is I'll put them on it for a year, have them come back, see how they're doing. If they're ready to get off the medication, we can have a trial without the medication. But usually they don't have to be on it forever. Syphilis. Syphilis, the Treponema pallidum, is the main cause of syphilis. And again, we have upwards of over 1 million cases in just the last year. So since the year 2000, we've had a significant rise of syphilis. I remember seeing this guy in Uvalde. This guy, he comes in all the time, about every 3 months. He's like, oh, what did I have syphilis again? And it's not in his primary, he has secondary syphilis every time he comes in. I'm like, bro, like, seriously, you gotta, like, do you understand that you are doing something wrong? Something wrong. He just completely doesn't get it. But usually these patients will come in as if they're primary. So it's not that it's painful, right? It's a painless chancre, it's a painless lesion. But anytime someone has something growing in their groin area, they're gonna usually come and think, I don't know what this is, it doesn't bother me, but this was not here yesterday and now it's here. So painless chancre that looks like it should really hurt, that is a syphilis. Okay? And if it's not treated, okay, or not treated appropriately, within 6 weeks to 6 months, about a quarter of these patients, not everybody, but about a quarter of these patients can develop secondary syphilis. Now, how these patients present is this diffuse rash. You haven't had a lot of dermatology. Have you had any dermatology yet? A little bit. But this is one of those things, one of the few rashes that will cause a rash on the hands and the soles. There's not many rashes that cause it. You'll see the palms and the soles that's associated with this. And then ultimately, if that is left untreated, these patients can develop tertiary syphilis. You may also see it as neural syphilis, but it doesn't just affect the nerve or the CNS, it also can affect the cardiovascular system and musculoskeletal. I saw this once in my phase 2 rotation at Campbell. The neurologist, so this 72-year-old guy comes in. He was sent by his primary because he had like an altered gait and he had these episodes of confusion, but all the other workup was negative. The neurologist spent probably 5 minutes with that guy, and he came out and he's like, I know what he has. I'm like, how do you know what he has? He's got neurosyphilis. I was like, how do you know that? Within 5 minutes, he knew all that. And so, yes, this guy was in World War II, I guess. No, it was a long time ago. I think World War II, and got it in World War II. It was never diagnosed, and then to the point now of neurosyphilis. And unfortunately, with neurosyphilis, whatever they have, whatever signs and symptoms they have are not reversible. But it's still treatable to help prevent additional degeneration or whatever it was. So I thought that was, so let me tell you what, Campbell is amazing. That was the most amazing pastries ever. So typically, we have serial conversion within about 3 to 6 weeks after exposure. And we want to identify this with, we've got a couple of different tests. We have treponema tests and we have non-treponema tests. So initially, we'll do a non-treponema RPR or VDRL. Okay? If that comes back positive, then they send a secondary, or even if it comes back negative, they send a secondary test. You need a treponema and a non-treponema test to confirm whether the person has it or they don't have it. The problem is the treponema is always a send out, so it takes several days to come back. So in the military setting, we do the non-treponema, and then they will send out automatically for the treponema. You've got to have those two tests for confirmation. So this is what I'm talking about. So we have a non-reactive BDRL or RPR. They're going to send that out for that treponema test. Okay? And if it's negative, then it's either really, really early syphilis or they don't have syphilis. Okay? So if they're high risk, they're multiple sexual partners, they have this abnormal grasp, or some weird lesion that you kind of get through doing a good history on them, then maybe they have early syphilis and you have to have them come back and repeat, usually 4 to 6 weeks non-treponema. If they have a negative non-treponema, they're still going to have a treponema test done, and that's reactive. It could mean that they have syphilis, could mean that they've recently been treated for syphilis and they're still having the antibodies as well. Or it could have been the fact that you have a false positive. So what they're going to do is they're going to do this additional test, this PA test. And again, that's going to be done in an outside lab. If you have both that are reactive, so the VDR-RPR is reactive, the treponema is reactive, that's bad. That's syphilis, right? That's really concerning. Or again, maybe they just got treated and they're still having the persistent antibodies. If your VRL and RPR is positive, but that non-treponema is negative, most likely you had a false positive VRL. So that's always really scary, right? Because when you're getting these tests back on these patients and non-treponema within a few hours, right? And so then you call them and say, I think you have syphilis. And then a week later you call them and say, I don't think you have syphilis, right? So it's a hard position for providers to be in because you certainly don't want to withhold information. So it's about counseling your patient. And look, we have this initial test that has to be done. The problem is this initial test has a high false positive rate. So it is likely, or it is possible, I should say, that this is a false positive. We have to do a secondary test. If that secondary test is negative, you do not have this. Okay? So I tell them from the very beginning, there is a multi-level screening for this syphilis. Okay? We'll get a first test, which is done immediately, and then a second test, which will be done at an outside lab. So you can kind of provide them information, the counseling they're going to need to get their mindset ready when they have some of these tests. Because on MHS Genesis, once that lab test is done, it pops up. And there are certain ones that they will not allow the patient to see, though, until the provider approves that they can see. HIV is typically one of those, and syphilis is another one. So how do we treat these patients? Primary, secondary, or if it's early latent syphilis, we can give them penicillin, 2.4 million units times 1. 2.4 million units times 1. For non-pregnant patients, doxycycline is an alternative. If they're allergic to penicillin, unfortunately doesn't have as high as cure rates, but if someone's allergic to penicillin, that's your option. If it is latent stage and kind of a later onset, then you still do the 2.4 million units of penicillin, but it needs to be weekly for 3 doses, a total of 3 doses. Alternative is doxy, but now you do doxy for 4 weeks. If they are pregnant, there is no alternative, so they need to have desensitization. So we talked about desensitization before. This may be a person that you send to infectious disease, and then ultimately you need to see allergy immunology so they can be desensitized to penicillin and then get the appropriate treatment. We got genital warts that can happen most commonly. We think HPV from the virus 6 and 11. On exam, these are usually pretty obvious, so they differ from herpes simplex because they're not blistered. They actually look more, what's the word I'm thinking of? Skin colored is the word I was thinking of. I know it's hard. Actually, I think that was skin colored. And they look kind of what we call verruca. So they look kind of like they're rough in appearance. And they usually come in 2 or 3, but not in clusters. They're going to be buried throughout the perineal area. Again, usually you can identify this on physical exam alone. You might have a couple lesions. If someone is immunocompromised, you might do an exam and they have, probably 50 to 100 different lesions that you can see. And this is usually a direct indication that these patients are immunocompromised. That would be a reason for you to do some additional testing, like HIV testing for these patients. Otherwise, most patients are going to have that many lesions of these HIV lesions. There's a couple of different treatment regimens. There's some over-the-counter medications like Podophylax that the patient can put on themselves. Imiquimod is also over-the-counter they can use. Otherwise, what we used to treat them as cryotherapy. We could treat them in the clinic. There's podophyllin that can be put on, TCA or BCA, which is a trichloroacetic acid or bichloroacetic acid. That's a topical medication. Usually they'll come back once a week for treatment. Even with the cryotherapy, it's usually once a week that they'll come back for treatment associated with that. Reasons to refer these patients is if they have significant disease. If they have multiple lesions, they're not really responding to topical. If they have multiple lesions, then it's really hard to do cryotherapy on 50 different lesions, right? So usually you have to refer them to dermatology because you're typically removing. Unfortunately, even if you treat these appropriately with cryotherapy or topical meds, there's still a high likelihood that some of these lesions will come back. All right. Let's go into talking about some different vulvar diseases. Remember the vulvar area, you think about the labia majora, the labia minora, the vestibule, and then everything within that vestibule area. Lichen sclerosis, usually we're going to see in the younger folks or those postmenopausal women. And the thought is maybe this is related to hormones, so decrease in estrogen. There might be a genetic component, or some people that have autoimmune diseases that have associated lichen sclerosis. Okay? But either way, it typically tends to be like more this chronic progressive disease. And usually these patients need long-term treatment, not just treatment for a couple of months. On exam, we'll often see more atrophied skin in the perineum, so it's going to be kind of that pale appearing. You might see some lesions that are on the labia, it might be kind of white, but not really typically extensively thickened. These patients will present with pruritus, so a lot of itching, a lot of irritation, again, a little bit of thickening, but not so much as what we'll talk about in just a minute with the prodicus. In the late stages for these patients, they'll get scar tissue that builds up, so they may have changes at the vaginal introitus where they have stenosis where it's scarring down. Dyspareunia will occur because of that vaginal introitus and the scarring down as well. And then we'll see on an exam what looks like cellophane paper. Okay? So when you pull the skin a little bit, it looks like you have crinkling of the skin, or we talk about cigarette paper, which most people don't even know what that is anymore. Oftentimes it goes not only to perineum, but it goes all the way down to the perianal region as well. Okay. So if we look at this picture, we've got some perianal involvement here. And then what I'm talking about for that tissue paper, that crinkled skin appearance, that's what we see right here. Otherwise, we have paleness that's here. Here we have a little bit of scar tissue where this is all kind of adheres together. And then we've got stenosis of the vaginal introitus. The difference between this and we talked about atrophic vaginitis. Atrophic vaginitis is going to look very similar to this, but you're not going to have that perianal region that's involved. So this typically goes down 80% of cases down to the perianal region. The biggest problem we have with lichen sclerosis is its increased risk for cancer. There's no vulvar cancer. So again, pale lesions go all the way down. We've got that cigarette paper up here in areas here. This patient also has some excoriations where they've scratched a tremendous amount. And so we see some open wounds up on the top portion of the pectoral area. Again, there's no specific cure, but we want to help treat their symptoms. And usually if we can start treatment earlier on, they're a lot less likely to develop that stenosis or the adhesion, labial adhesion. So hygiene modification, we want to talk to them about using maybe topical petroleum at night, which helps reduce the itching. We want to talk about topical corticosteroids, and the majority of things we're going to talk about for vulvar area is going to be clobetasol. And that's because it's not going to thin the tissue an additional amount if you use a stronger topical steroid. Usually once we do that, within the 6 to 12 weeks, these patients will already see some improvement of their symptoms. If at 6 to 12 weeks, we're 3 or 4 months into this, they still have no improvement at all, we want to consider referring these patients to OBGYN or to Women's Health. And then they can ultimately put them on topical retinoids or 5-FU therapy. If they think that these patients need additional evaluation, they will actually do a biopsy again because of that risk for vulvar malignancy, up to a 5% risk in these patients. So any lesions that they have that are persistent, despite treatment, they're going to do biopsy of those lesions. Usually once we start the treatment on these patients, and definitely after biopsy, usually every 6 to 12 months is appropriate follow-up in the patient to make sure they're still well controlled and make sure they don't have any new lesions that are developing. If they're having a lot of itching, there's nothing wrong with prescribing or having these patients wear cotton gloves at night. That tends to help reduce the amount of scoliosis that they have, which ultimately can be a secondary infection. We have lichen simplex chronicus, right? Again, this has had more of that thickened, kind of leathery appearance in the vulvar skin. This much less likely to have any sort of change in malignancy that occurs with this. But what happens with these patients, they have what's called this itch scratch cycle. So of course, the more they scratch, the more it itches. The more they scratch, the more it itches. So usually these patients will come in with this significant pruritus. Okay, it can not only be part of the labia, but it's going to extend all the way into the folds here and up on the inner portion of the thighs. And on exam, you have this thickened skin. It looks gray, it looks leathery appearance, if you will. Okay. And that's going to be kind of your hallmark for this lichen simplex chronicus. You do have really kind of some pale areas, but the difference here is that thickened area that we can see out here and out here. Causes tight-fitting clothing. So we talked about Lululemon last week. Patients walking around after they've been working out for all day long in the same clothes. You want to talk to your patients about good personal hygiene and making sure that they're changing their sweaty clothes pretty frequently. You also want to talk to them about personal hygiene products. Make sure that they're using the same product. Look at their products, and maybe that's the cause. Laundry products. A lot of people will buy just what the cheapest laundry soap is out there, and they'll identify that after I change my laundry soap. So it's good history on these patients is what really identifies usually what the underlying cause is. Sometimes it's a food sensitivity that they have that they didn't know that they had. But they would introduce them to their diet where they may say, after it always seems to be worse after I eat something. Treatment is going to be topical steroids, clobetasol. Usually at bedtime is all that's needed for a month or so. Within that month, they usually have some improvement. You can continue longer than that if needed. Of course, we want to eliminate any identifiable triggers. And then petroleum jelly at night. Sitz baths tend to work as well. Oral hydroxyzine is usually pretty good to help with that pruritus. That can help with the lichen sclerosis as well. And then we talked about wearing cotton gloves or sclerosis at these patients as well. Because of that intense itch scratch cycle, cotton gloves really tends to work pretty well for these patients. Ultimately, if you tried the clobetasol, you've done the cotton gloves, you're doing petroleum jelly, and it's not improving, or if you have a specific area that's not improving, these patients need to be referred for biopsy. We can get just contact dermatitis. Is there a place called Lush? Does that sound something that, okay. So I I don't go to that place, I don't have anything from there. But a friend of mine called me last year, really close friend. And she was like, oh my God, her son got her this stuff from Lush, which is like something with bath and body stuff, right? And she said, I use that stuff. And she's like, I'm on fire. And I'm like, what do you mean? What are we talking about right now? She's like, she's like, and she has a really foul mouth. And so she talked about, I'm like, oh, wait a minute. What are you talking about right now? She's like, what am I supposed to do? Like, mine is on fire. And I'm like, well, like, did you try this? You tried this? She's like, it's that dang Lush that I use. I know it is. And she's like, I was gonna go to the emergency department. I was like, don't go to the emergency department. Do not go to the emergency department for that. And so ultimately, I talked her off the ledge from going to the emergency department. We got her all squared away. But I think she was a couple of weeks of trying to get this thing all taken care of. So you can have contact dermatitis from stuff like that, from new personal hygiene items, some really cool things that you get for Christmas, right? You're going to use those things because you feel obligated to use those things. So if it's an irritant problem, they're going to have signs and symptoms almost immediately, within the first couple of hours of using this. Another common thing is nickel. People will come to see you and they'll have a big rash right where their button is for their pants. And it's usually because they have an allergy to nickel, even though they've worn pant jeans their whole life. Okay, 80% of the time, it's going to be some sort of irritant. Again, these patients have symptoms almost immediately. 20% of the time is the problem because it's an allergic component. And so these patients have, over the last several months, have developed this irritation. And that was, it's a lot harder because now you're trying to figure out why are they having the irritation. They're going to still have this pruritus, but really it's an allergy that they have developed sometimes it's allergy to something that they're eating, sometimes it's something in the air. But what the difference is how they present with more of a localized reaction instead of a diffuse reaction. Okay, so ideally, if we identify the problem, we're going to discontinue that problem. Petroleum, topical jelly, or sitz baths tends to work pretty well. If there's any evidence that there's an underlying infection, especially if it's a chronic problem, you've got to treat that. Maybe it's a fungal problem. Maybe it's an infectious etiology. We have cellulitis, we want to treat that. Otherwise, topical corticosteroids, clobetasol tends to work. Only if severe are we going to put these patients on oral steroids, because usually the oral steroids is going to be a longer course of action. And I like steroids a lot for about 5 days. Really beyond 5 days, a lot of patients tend to have a reaction to those steroids. Cool packs to the groin, so I know this is weird, but I tell people get a bag of frozen peas or frozen vegetables and use that, because the good thing is they hold that cold, and you can wrap them up in a towel and cool compress for about 5 minutes, and that tends to really help. Hydroxyzine tends to work, and then, I know weird, but cold yogurt on a sanitary napkin. You can Google it. Definitely works really well for these patients. We have direct contact to the area. It's not going to be cold enough to cause any sort of cold injury to the area, and it provides significant relief for these patients. So usually you leave it out for about 5 to 10 minutes, and they get relief for a couple hours after using this. Now, I don't know what kind of, like, usually I'll just use like plain. I don't know, like, I would recommend like fruit yogurt or like that. Just plain yogurt. And I know that's a little bit the amount patients are. So that's what I'm talking about, just a local reaction. Like, why is this so focal? Why are you having only irritation in that area? This is more of an indication that they came in contact with something that's causing just that local inflammation. There's a lot of things that can cause this. Okay? And so obviously you don't need to memorize all of these things, but just in your mind think about, were they recently exposed to something new for personal hygiene wise? What about, are they using a new condom that they didn't use before, and they have a latex allergy or a latex sensitivity? That could be it. Were they recently on some medication for like a vaginal infection where they use topical medication? Did you just poke yourself in the eyeball?
I did not.
I feel like you feel like very close. I feel like you're very close. So you want to just think about potentially something that may be in contact. Okay. Lichen planus. Have you learned about that in derm yet? Okay. So lichen planus can also occur, pretty uncommon in the vulvar area at least. It affects males and females equally, typically 30 to 60 years old. And we're not really sure what is the causative agent of lichen planus, but usually seems to be like T-cell mediated. You want to think about these patients that have new onset of this as maybe some medication that they're on. The anti-inflammatories, NSAIDs can cause this, beta blockers, and then some other things like methadone. We use that for blood pressure, penicillamine, quinine, we don't use that stuff anymore. But NSAIDs and beta blockers, I've seen a couple of times specifically associated with those medications. So have that on your list of suspicion if they come in or something you think is lichen planus. Oftentimes involves the cutaneous and the mucosal surfaces. So these patients can come with not just pruritus, but those erosive lesions that you may see. There's a couple, 3 different variants actually. The most common thing we're going to see in the vulvar vaginal area is going to be the erosive. Okay? It's also unfortunately the most difficult to treat. But you can get this on the skin, the lower extremities. And how you're going to identify this is this purple, pruritic, polygonal papules and plaques. Okay, so you may not be able to see all that well in these pictures, but if you look at these pictures, this has an entire vaginal area, that skin kind of has a purple hue to it. And when you see it on the skin and lower extremities, it's the same way. It's like, you're like, wait a minute, why do I notice it just has this purplish hue to it, and it's more polygonal, so it's not circle. Okay, it's really very distinct when you see it. Again, I've only seen this a few times, but I remember one of my very, very good friends that we do trips with every year, she had this, and I was like, have you got that? Like, that is lichen planus for sure. And she went and they did a biopsy, and it was lichen planus. But you also see these erosive lesions. So in the setting of this purplish discoloration, you got these erosive lesions, and then if it's been going on for a while, you're going to start seeing that stenosis, that adhesion. So this is labial adhesions here. Usually this is open, this is all adhesed in. So you can imagine these patients may have associated dyspareunia because of the adhesions of the labia and also the vaginal insurance. We treat these patients, again, vulvar hygiene. If they're on a medication, if they're on an anti-inflammatory, they're on a beta blocker for the hypertension, discontinue it. I would probably put them on a different antihypertensive, but I would discontinue the medication that they're on if you feel like it's associated with this. Topical clobetasol, again, is our treatment of choice, again, because it's not a super high-powered topical steroid. Hydrocortisone suppositories. So we typically use hydrocortisone suppositories for hemorrhoids, okay? But now we can use it as a place them intravaginally, and it's a slow release of this topical steroid. It tends to work really, really well for these patients. 25 milligrams is what they typically come in, and you can use that per vagina at bedtime, and these patients tend to get pretty big leak. Another thing you may want to do, depending on the degree of their signs and symptoms and their physical exam, you may want to refer them to physical therapy. So physical therapy can help with them with using different vaginal dilators for a sensitization to help them so they don't have so much pain with intercourse. Who knew physical therapy did that? I didn't know. Oral steroids only if the topical steroids or topical hydrocortisone does not work. If they have significant scar tissue, significant adhesions, they may need to be referred for surgery that can lyse those adhesions and improve their quality of their life. Okay, so we have Bartholin cysts and Bartholin acid. I know I keep distracted by the time because we started at the half, and I'm like, what were we time? Bartholin cysts or Bartholin acids. Remember where are Bartholin glands located? Bottom 4 and 8 o'clock position. Okay, so on the outside of the vaginal introitus, the labia, the majora area, and then in the 4 to 8 o'clock position. So these areas can get cysts in them, or they can get abscesses in them. So if it's a cyst, pretty common in reproductive age, females, usually don't have a lot of pain at all. They just come in like, I got a lump here, and I didn't have a lump here, but now it's there. Typically it's going to be unilateral, very rare to be bilateral unless they have some sort of STI that's causing it. And very uncommon over the age of 40. So if patients come in and they have a cyst in the 4, 8 o'clock position over the age of 40, really the recommendation is probably just to send them a OBGYN. They can IND it, and then they'll take they do a biopsy of the core, and they'll send that off, because those patients are at much higher risk if this is Bartholin gland cancer. And you can get isolated Bartholin gland cancer, so be very high index of suspicion on those patients over the age of 40 or postmenopausal patients. Abscess. Now these patients are going to come in like they've been riding a horse for a week or so. They're going to come in, they got that very classic walk where their legs are kind of spread wider apart because it's super, super painful. They may even have systemic sinus symptoms. They have a low-grade fever, 101 or so. They have significant pain, and for these patients, it's a much higher likelihood that's associated with gonorrhea, chlamydia, or STIs. You want to make sure you get that good history on these patients. I would also consider testing them for that, either with a vaginal swab or urinalysis, just to make sure. Again, you're not going to get those labs back typically that day, especially if it's a vaginal swab. Usually it's a couple of days before that comes back. Urinalysis is usually several hours. But if they have high index of suspicion, you talk to your patients about their sexual behaviors, then you can go ahead and prophylactically treat them for gonorrhea and chlamydia, in addition to treating the abscess itself. So these guys have erythema, looks like it's painful, looks like it's infected, and that's that abscess. Treatment, if it's a cyst, you actually don't need to treat it at all, but a lot of times the patient's like, oh no, I want it gone. Like, I can do that. This is going to be very, very painful. This is one of those grab the knife and bite it type situations, right? So this is pretty darn painful. You can numb them up. And once you numb them up, they tolerate the procedure very well, right? But you're numbing them up. And the numbing medicine hurts, and the needle hurts. And so these patients typically are going to scream. But if they want it gone, you can certainly do that. Incision and drainage alone is typically discouraged because it usually is going to come back. And so once we incise these, we're going to put what they call a word catheter, and then I'll show you what that is. Again, if they're postmenopausal, we can cut these open, but they need a biopsy. So usually if it's a cyst, I'm going to send them to OBGYN since they don't need immediate treatment for this. Okay. This is a word catheter, so it looks like a little Foley. Comes in a kit. And in the kit, you have the catheter itself, and then you have a 3 cc syringe. And how this works is once you do a little stab, so you're not like taking, so normally we do abscesses outside of the Bartholins. We're gonna make a pretty healthy incision, okay? Because if you make a real small incision, it's very apt to close up pretty quickly. We want that to stay open, so you're gonna make a real healthy incision. This is not the time to do that. Okay? This is a stab. Okay? And this is usually a stab like this, because there's abscess material in there, you've injected them with lidocaine, so now this thing is under pretty decent pressure, right? And once you do a stab, it's gonna go. So you gotta make sure that you're prepared for that with your goggles and your gown and all that kind of stuff, right? But this is a stab with either your 11 blade or 15 blade, because we want a real small hole. If you make an incision that's too big, the tip of this will go into that hole. Once it's in, now you're going to blow it up with the fluid, with the saline. Okay, so you're going to put it in. Once you do your incision, you're going to milk all the stuff out of there. You're going to put the end of this into the area of the incision. Once you do that, at the end of this, right here, there's a place where your needle goes. Your needle goes in there. You've got a syringe full of 2 to 3 cc's of fluid, of normal, usually saline. And then you put that in there. And once it's in there, it's going to hold in that incision. Meaning, if you make the incision too big, it's just going to come out, right? So that's why we just want to stab incision, and we'll put that in there. That makes sense? So you got a little tiny hole. Inside there goes the end of this, okay, not blown up. You're going to take that, after it's inside, you're going to take your saline, you're going to push it in there, and it's going to blow it up like a Foley catheter. And that's going to hold that in there. And then you're going to take the end of this, and where are we going to put it? Into the vagina. This gets tucked into the vagina, right? And that's where it goes. So this is your cyst. This is your words catheter inside the cyst, and this is the end of that catheter into the vagina. Okay? And it stays there. Anybody know how long? 4 to 6 weeks, ideally, until it falls out. And oftentimes it'll fall out in a couple weeks, but if we can keep it in 4 to 6 weeks, because what you're trying to do is you're trying to allow the inside that to kind of epithelialize, okay? So we have less likely of reoccurrence. If you only IND this, or a lot of people nowadays like to do a needle drainage, it's not going to work. So you're going to get some stuff out, but it's going to come back in the next few weeks. So you don't just IND and just needle drainage is not recommended for these. If it's an abscess, we're still going to IND it. We're still going to do that word catheter placement, but now these patients need antibiotics. Okay? They need antibiotics. And that's because it's an infection. Especially if they come in running a fever, it's warm to the touch, it's erythematous, that's an indication of infection, they need antibiotics. Bactrim, oxalic acid, augmentin is okay, Metro is okay. If we suspect MRSA because of a history of MRSA, then we usually will do a double coverage. But just the biggest thing is takeaway is cyst doesn't need antibiotics. Abscess with redness and fever, that needs antibiotics. Our vulvar hematoma, okay, the vulvar are very, very vascular. Okay, so what you may see as a young girl riding her bicycle, feet slip off of the pedals, and she hits her groin area on the bar, right? So that happens not infrequently. That may have happened to your own children, okay? But the vulvar area is very, very vascular. And so the parents will bring these patients in because like, oh my gosh, there's so much swelling down there. Yes, it can. It can swell a tremendous amount. So things to get concerned about, so not only can it happen with straddle injury, aggressive intercourse, of course, sexual violence, so you got to make sure you have a good idea of why this happened, how did this happen, and if there's anything at all concerning about that story, then you may need to be calling CPS. Okay? You can't let a patient go home if there's anything at all concerning about the story. Even on the military installation, it's your responsibility to do that. Okay? Most places are going to have some sexual prevention folks, same people that work in your hospital, so those are the people that you can call. These patients typically will present pretty significant discomfort. Your physical exam, if you have a rapidly expanding hematoma, meaning I looked at this and 5 minutes later I come back and I'm like, whoa, that is way bigger. That is very concerning. Right? If they have tachycardia, if they have hypotension, that would be very interesting. And they have tachycardia from pain, so you can treat that. But if that persists, that would be very concerning that they have a deeper injury and they're continuing to bleed. Those patients need to be transferred, or they need surgical evaluation or some peds surgery evaluation. And sometimes they'll have to cut that open, get the clot out, and then they'll have to clamp the vessel that continues to bleed. Most of the time, that doesn't happen. We can do cool compresses, we can do, pain medications, and it typically is okay. But it's really about monitoring these patients. If you can't get a really good exam because the patient is all over the place, so screaming and carrying on, sometimes they have to be sedated to be able to get a good exam. A lot of times a good exam includes a digital exam so that you can go up the inside of the vagina and make sure you don't see it and feel enlargement on the inside of the vagina, indicating that you have continued bleeding. And then, should we just finish? Yes. Okay. So sometimes you get a vaginal laceration, okay? People have piercings all over the place. Men have piercings in their penis and they want to have intercourse. Well, that piercing can lacerate the vaginal wall, okay? And these patients will come in with significant bleeding. Blood everywhere, okay? And so if that happens, the key is identifying that it's there and then they just sew it up. So it's not difficult to treat, it's knowing, okay, what happened, because a lot of times you'll think women, oh, they're probably having a miscarriage, that's how much they're bleeding. They're bleeding pretty significant, they're probably having a miscarriage, so you're going down that whole route, But it's important to say, okay, what were you doing just prior to the onset of the bleeding? Because what's gonna happen is they'll have that laceration, they're not coming in 3 or 4 or 5 hours from now, they're coming in 20 or 30 minutes because they're bleeding so bad. But it's about getting the history that they in fact had something in the vagina and something kind of lacerated it. Then it's calling OBGYN, they gotta come down and they will use something to open up the vagina as much as they can. They'll use the absorbable sutures and they'll sew it up and look out the door, no problem. All right, that is all for today. Thank you.
Hey, one second.